Okay, so welcome everyone, welcome and thanks for joining us. I understand that in many places is the end of the semester, which many of you are looking forward to. So today's talk is part of the distinguished seminar series that we have at the Hariri Institute at Boston University. And the talk is also part of the ML in Medicine seminar series. The ML in Medicine seminar series is a seminar series that we are co-organizing, we participate, and it is a joint effort with the University of Pittsburgh and the University of Toronto, and is focusing, as the name suggests, on machine learning, AI, models, and more generally computationally driven work driven by data applied to a variety of applications in medicine, healthcare, and public health. So I will first introduce the host for today's event, for today's seminar. But before I do that, just a few administrative notes. This is a virtual talk. Please hold your questions until the end. You are very welcome to use the Q&A feature of Zoom, and you can post your questions there, and we'll be monitoring and bring those questions forward at the end of the presentation. Also, today's talk is being recorded, and it will be available after the seminar at the Hariri Institute's YouTube channel. So let me now introduce the host, Kayhan Batmangelic. He's a new faculty here at Boston University in electrical and computer engineering. He's also one of our newest junior faculty fellows at the Hariri Institute. Kayhan came to us from the University of Pittsburgh and has been one of the founders of the ML in Medicine seminar series. So Kayhan, floor is yours.
Thank you very much. Thank you for kind introduction. It's our great pleasure to have you, Emre. Thank you very much for accepting our invitation. We have read like many of your exciting paper and your amazing package. So it's a great pleasure to have you. Emre is a principal senior researcher at Microsoft Research, where his research interest spans causal inference, machine learning, and AI's implication for peoples and society. Emre is a co-founder of DoWhy library for causal machine learning, and he received his PhD from computer science department in Stanford University. It's our great pleasure to have you. I'm very excited about your talk. The floor is yours.
Thanks so much, Kayhan. Thank you, Anders, for inviting me, and I'm excited to be here. As Kayhan mentioned, I don't know. My understanding is this is a broad audience, so I'll take a minute to give you a sense of my background, so that you can put my comments into context today. I'm coming at this area of causal analysis for health analyses with a strong computer science background. I started my research long ago on distributed systems and applying machine learning to computer systems problems, and over time slowly migrated to where I am today, which is working on causal inference techniques broadly, and going deep into a couple of verticals to make sure that these analyses actually have an impact on how we make decisions and understand the world today. So a bit of a cross-domain perspective. I'm definitely not a health expert. I lean strongly on my collaborators in Microsoft's Health Futures research teams for that. And I will say right now that obviously if there are if you hear anything good in this talk, it's due to them, my collaborators, and if there are any mistakes, that's on me. Great. So at the beginning of the talk, the first thing I want to do is give away the whole story, all the takeaways. So what I'm going to try and cover today is first talk a little bit about what we see as the core challenge in causal analysis, that the difficulty we see people having is not in the specific methods that we need to be using to solve problems correctly, but actually in the initial causal framing and the validity and understanding the validity of the analyses. That is, people are falling over when they're trying to frame their domain-specific problems, including their health questions, in the formal language of causality, so that we can make sure that it's being done right. Kaihan mentioned the software package that we've built, the DoWhy library. Now it's part of a broader umbrella of Python-based causal analysis tools called PyWhy that brings together a number of different software packages together. And through this work, we're seeing that the role of causal software is not just to provide implementations of algorithms, but also to scaffold this end-to-end process to help people ensure that they are following the best practices for causal analyses from the beginning all the way to the end. Now, the software we work on is very much a horizontal platform. It provides, an analysis for causal APIs and methods for causal analysis broadly. And here in this presentation, we'll be touching on what it would mean to take this type of horizontal platform and specialize it for a particular domain, for health. And what we see as the big opportunity here is the ability to use domain knowledge. Once you know what problems your tools are being applied to, using domain knowledge to better bridge that gap that we're seeing between how people frame their problems and what the causal analysis tools can provide. We can bridge that if we know more about the specific domain. The last point I'll cover in this talk is based on recent work that we've been doing to understand how large language models might help this situation. And in particular, I'll dive into a little bit of our experiments on how large language models seem to be capturing much of the domain knowledge that previously was the burden of the human expert to express. And now we think that we can at least bootstrap, help the human brainstorm more of this domain knowledge automatically or semi-automatically, and just make life easier for the human analyst in that way. And we're very excited about that. Okay. Right. So there's I'm going to start with a little bit of motivation about why, one of the reasons why we think it's important to apply causal analyses to better understand the effects of, sorry, I just got a report that my laptop is running out of batteries, which would be unfortunate. Okay, yes, so there is a, sorry, after seeing that my laptop is running out of batteries, I'm checking and my laptop is plugged in. So I'm a little concerned that something's going to go wrong. But in the meanwhile, let's just continue and see what happens. So medicine today is rather imprecise. For example, the top 20 drugs that are given to people, we see that 80% of people who receive these drugs are actually non-responders. This results in a significant wasted health spending. And we believe that well-designed observational studies can augment randomized control trials and other methods at getting at a causal understanding of the effects of medication to help us improve the decision-making around when we think a drug is going to be effective for a particular patient with their specific illnesses. And we think these observational studies can augment a wide variety of tasks from early research to clinical trials to post-market analyses. And we think that these types of studies can provide a path to accelerating the clinical research in particular and reduce the time it takes to take a drug to market. Basically, we think that this can, looking at the data we already have on hand, can help us do things faster and more efficiently. and in some cases also help us get to more detailed information by helping us understand, say, heterogeneous treatment effects. What happens to how the drug works, not on average, but for specific subpopulations, more effectively. A big significant question we have, of course, with observational studies is ensuring that that our observational studies are actually giving us correct results. So we have to ask ourselves, how can we validate these models based on real-world evidence, based on previous trials? How do we validate our hypotheses and ensure that our methods are actually giving us reliable results? And we care about this reliability because we've seen so often how observational data can lead people to the wrong conclusions. For example, a 1999 study concluded that the use of nightlights by young children caused myopia. I mean, this was big news. It even made it onto the evening news. But the next year, 2 studies refuted this finding. And it turns out that the problem with the initial study was that it ignored a common confound, which is a typical problem with many observational studies. The confound was that parents with myopia themselves were more likely to use night lights at home, and this caused a statistical correlation between the incidence of people using night lights and this heritable condition, therefore seeming to create a causal association when there really was none. In another case, many observational studies found that vitamin C and E reduced coronary heart disease and other illnesses. But these effects were later refuted by randomized control trials, the gold standard, obviously, for understanding causal effects. And upon further analysis, it was found that there were multiple confounds unaccounted for in the initial studies, including socioeconomic indicators and behavioral factors. More broadly, in a review of 12 papers making 52 claims from observational studies, Young and Carr found that none were reproduced in follow-up RCTs, and several were actually contradicted. Now, I just cherry-picked a couple of examples of observational studies that were wrong. I chose these examples because they're particularly clear, and it's very easy to see how a specific confound could have led to a bad result. But these are also rather old studies, 10 or 20 years old in some cases, and we'd hope that we've learned a lot about how to run an observational study in that time period. And I think we have, but it's worth noting that similar problems continue to plague us today. So, for example, at the beginning of the COVID pandemic, many research labs around the world built classifiers that would take a chest scan and try to identify whether the patient was suffering from COVID. This was critical, if you remember, at the beginning of the pandemic, to know whether you were actually sick with COVID or not. We were looking for ways to tell. Two follow-on studies by Roberts and by Winans found that none of these classifiers were actually reliable. None of them were robust enough to use in practice. And the issue was each of these fell prey to identifying false correlates based on the way that their training data sets were collected. So, for example, one classifier was built on a set of chest scans from a hospital where the policy of the hospital was to allow patients to either sit up or lie down for their chest scan, depending on what was more comfortable for them. This led to, of course, the people who were sicker opting to lie down. And this shows up in the chest scans. And then the image analysis mechanism, instead of learning the signs that tell you whether someone has COVID based on the chest scans, actually learned the signs of when someone was lying down, because all the COVID patients were lying down. And so this means that, this means that when you transport this classifier to a different hospital that has a different policy, it's not going to be flagging what you think it should be flagging. And there are many such examples. In another training data set, all of the non-COVID chest scans were actually pediatric scans because children weren't getting sick early on in the pandemic. And so this meant that instead of a COVID classifier, what was built was actually a pediatric scan classifier. And so each of these can be thought of as confounding factors in a causal analysis setting, and still quite a challenge for our analyses today. Why is this so hard to get right? It comes down to two fundamental challenges. One is that when we're calculating causal effects, we're calculating the difference between two outcomes, one of which is the real world which we observe, and the other is a counterfactual we're never going to directly get to see. We can at best estimate it. And this leads to challenges in validation. We come up with a number that we can't directly measure. So we have to make a lot of assumptions to ensure that, to convince ourselves that this number is correct. And the second challenge is that these assumptions can't
Probably there was an issue with the computer.
Did we lose the speaker?
Yeah.
Yeah. So the laptop was right.
Laptop was right. Yeah. So let's. Yeah. So
Let's wait a few minutes.
yeah. I apologize, the audience, for the issue with the speaker's laptop. He just messaged back, and he's logging back. Thank you for your patience. Oh,
Hello. I'm very sorry for that. My laptop did run out of batteries and I had to change offices to get to a power adapter that works.
Okay, that's
All right, so we can continue right where you left, Emre.
That's right. Yeah, thank you for your patience. Yes. So yes. So secondly, the second challenge is that these assumptions can't come out of the data. They have to come from outside knowledge about the system and our assumptions. It turns out that the data that we get to observe from a system is theoretically never enough to without significant assumptions is not enough to identify the correct causal mechanisms. There'll always be multiple competing hypotheses that would be equally that would be able to equally explain the data that we've seen equally well. This means that we do rely on external domain knowledge and assumptions to help us help ensure that our analysis is correctly framed. Now, until recently, we've always said that this domain knowledge has to come from the human analyst, and that's been a significant burden. And as I said, one of the main places where we see people having trouble when trying to apply causal methods to their problems. At the end of the talk, I'll talk about how large language models might be helping us with that challenge. Now, so the work we do in causal analysis, we do obviously fundamental research, but we also want to get our analyses into the hands of practitioners. We see this as being a bit of a flywheel, learning from the problems that people see in practice to inspire then the research that we do and getting into a really nice cycle with that. So as part of these efforts, we've built an open source suite for causal AI that consists of 4 packages. First is DoWhy. This is our end-to-end library for causal analysis with the explicit intention of scaffolding best practices. So DoWhy starts with helping the analyst capture their causal assumptions, then walks them through the step of identifying the right causal strategy, running the correct statistical estimators, and then validating the end-to-end process, including their initial assumptions as much as possible, or running sensitivity analyses if not possible. Now, our sister library, EconML, complements DoWhy with the focus on sophisticated estimation methods, in particular those based on the latest advances in causal machine learning. Now, the Causal project aims to help people develop an initial understanding of the causal mechanisms that might be underlying a system. So by using the latest deep learning methods for causal discovery and end-to-end inference. Now, Causal is able to really help people bootstrap their understanding from data alone, but it does get you to this point where you do have to provide a little bit of extra domain knowledge to disambiguate, for example, some of those areas I mentioned earlier, where there's, say, 2 competing models that explain a data set equally well. And these 3 are all Python libraries: DoWhy, EconML, and Causal. The DoWhy package then builds on top of these to provide a no-code interactive tooling experience for data analysts who don't want to program in Python to get this kind of functionality. Together, these libraries end up empowering data analysts to ask causal questions, follow the best practices, and then defend their causal evidence to an audience of decision makers. DoWhy and EconML are often used together and are the 2 older libraries in this suite. They have reached significant milestones in usage and and are used broadly across the industry. Causal and DoWhy are newer packages, but garnering strong interest both from the research and practitioner community. We've taken DoWhy and EconML now and put them into a community-governed open source organization in GitHub to attract a broader set of collaborators to these projects. So we have active academic and industrial collaborators from CMU, MIT, Columbia, Johns Hopkins, Amazon, and several other companies. And we're seeing a broad academic industrial usage that we're really happy to learn from, including some production deployments, from what we understand. Some of the work that we're continuing to do includes expanding our library to support new causal tasks beyond effect inference, also incorporating robust prediction, representation learning, and attribution or root cause analysis type of tasks as well. So, from the usage that we're seeing, both internally at Microsoft, the projects that we're directly involved in, as well as external usage of our open source packages. I wanted to give you some context of the kinds of things that people are doing. So examples of some of the causal questions we've encountered include customers asking about the impacts of past and prospective marketing campaigns and investment decisions to understand how they improve their business. What's the return on investment on some, say, new program that's been funded at a company. We have partners in agriculture who are investigating the effect of farm management practices on soil carbon sequestration and asking how to attribute manufacturing slowdowns in factories to underlying causes, such as the variability in the quality of inputs or the tuning of machinery. And based on what we're seeing, we highlight 3 frontiers where we see the biggest need for research. The first frontier I've mentioned several times in this talk already, so you won't be surprised that I put a lot of importance on the fact that we see people having a hard time encoding domain knowledge. Here we have been looking at where we can get new sources of domain knowledge and tooling. We've been looking at how we can bootstrap causal knowledge from existing artifacts that capture causal knowledge, such as trusted simulators in a particular domain. This is in many domains, trusted simulators exist and have been built up over decades, and looking to them to give us a stronger causal understanding is a way of getting at that knowledge without burdening a human analyst, for example, to produce all of those details that the community has embedded in the simulator over time. The one that is that we see the most promise in at the moment is actually, though, large language models. They seem to capture domain knowledge gathered from all of the documents and texts that have gone into the training data sets. And we see this providing an ability to help an analyst bootstrap their understanding of a system, brainstorm about new areas, and even critiquing the assumptions that a human analyst is bringing as well in a really nice loop. I'll say more about this paper, but if you're interested in learning more about our work on causal reasoning and large language models, we have a working paper we've posted to archive. The second frontier that we think is really critical to broadening the use of causal analyses for decision-making is to expand our causal analysis methods to work over high-dimensional data, text and images. A lot of the places where we want to use causal analysis for stronger decision-making, the information that we want to use is actually captured in high-dimensional data formats like these, not in tabular data amenable to use by conventional algorithms. And the third frontier is really developing new approaches to validation so that we can trust the results that we're getting and make sure that we're not falling into some of the traps that the observation studies I mentioned earlier fell into. I'm looking at the time, and I'm going to kind of skip over a couple of slides to make up for some of the disruption. So here, what I'm showing is what we see as the four-step process for best practices for causal effect inference. The first, that's what we think is one of the key functions of a causal analysis software platform, and then we'll build on this. Talk about how when you have knowledge of what domain you're working in, you can use domain knowledge to augment and improve this process beyond what's possible in a horizontal layer. So at a horizontal layer, for example, it's critical to ensure that measurements match up with what we think they mean semantically. There isn't always a lot we can do here other than prod the user to think about this very carefully. For example, in one of our agricultural studies, we learned that continuously sampled measurement of chemicals in water flowing from a field was only valid when another measurement in that data set indicated that a specific pump was running. If that pump wasn't running, the water measurements were stale and invalid and didn't mean what we thought they meant. And this type of detailed understanding of the data and the collection mechanisms is something that's hard to provide general purpose support for, but is one of those places where if you have domain-specific knowledge, if you're working at the health layer, understanding how common practices for measuring for collecting measurements are done, then I think there's much more that can be done here to ensure that that the data means what we think it means. The second part here is when we're first framing our problem is making sure that the causal assumptions are correct, that we're capturing the kinds of potential confounders and other mechanisms that might invalidate our interpretation of a study. As an example of the kind of platform support we had here at the horizontal layer for a couple of years in the DoWhy package, we actually had a warning on our system if you didn't mention any hidden confounders. We would say, you set up a really nice problem, but you seem to claim that there are no hidden confounders and that you're observing everything. Are you really sure that's the case? And we would make someone, push the letter Y to say yes before they could continue. We kept this in there for a while. We wanted it there as an educational mechanism, but in the end, we had too many complaints that this was disrupting people's workflows. And so eventually turned it off by default. But that's the kind of sentiment we want to bring to make sure that people are questioning their analysis very critically. Once the problem has been set up, we have the causal assumptions, then we can provide identification algorithms that analyze these assumptions together with the data sometimes to identify valid analysis strategies. What's the right way to take this causal question and answer it with the data that you've observed? And then given that strategy, the estimation step becomes a statistical problem. We can introduce new assumptions on functional forms, for example, but now we know what we need to be calculating, and we just need to figure out how to trade off bias and variance to calculate that in the best way for the data that we have. And finally, once we get our results of, and we believe we know now what the effect is of a particular treatment that we've been studying through our observational data analysis, then we have to go back and scrutinize all of our assumptions very carefully and validate, refute, or run sensitivity analyses to make sure that we understand how much we can trust these results. So what does this mean for a causal health layer? So based on our experience, extending a software platform for causal analysis to support health analyses requires more than simply incorporating the additional algorithms designed, for example, for longitudinal data, appropriately handling unstructured medical image or text data. What we think a health layer for causal analysis really needs to do is incorporate best practices that are specific to health, incorporating more sophisticated assumptions about measurements and data to protect against a wider variety of threats to the validity of the analysis. For example, rather than requiring a data scientist to begin by encoding all of the relevant domain knowledge from scratch, this software layer can bring in additional existing domain knowledge about common areas of inquiry, standard practices, etc. And while our causal platform is focused on scaffolding, causal analysis, and best practices, it does so in a domain agnostic manner. And so we think that going to a domain-specific manner can help by ensuring that the data analyst doesn't have to translate their domain knowledge and frame it correctly, etc. Now, we've been looking at a specific health task to get between the Causal AI team and the Health Futures team, and that is using real-world evidence generated from real-world data to augment traditional randomized controlled trials and recreating randomized controlled trials from real-world evidence data to understand how well our observational study approaches are able to recreate that ground truth RCT knowledge. And we've been working with real-world data and a medical provider for this purpose. Here, the main task that our pipeline addresses starts with extracting the relevant data from electronic health records. We use natural language processing and other heuristics to process patient data and extract out the relevant information from the electronic health records, including the clinical text notes that contain a lot of the important information for understanding and contextualizing the other measurements. This creates a unified structured data set, and then we use a latent variable model for data imputation, correcting other data corruptions that we think are due to measurement errors or poor model predictions. Then the second step then is to go through the causal analysis steps to recreate a simulated randomized controlled trial. And so from here, from all the patients' data that we've gathered, given a particular question that we want to ask, we identify the subset of patients that are relevant as either treatments or controls for this question, and then run this through a causal model that simultaneously estimates hazard ratio and also generates patient-level counterfactuals. The same model can be trained on more relaxed criteria to answer real-world evidence questions that go beyond the scope of the original RCT as well. So, for example, answering questions about heterogeneous treatment. Now, working with so we've been working to recreate several RCTs, but through this process, structuring medical data and then running the causal model to analyze the effects of our the areas of interest here. So we're particularly focused on the effects of cancer treatments in individuals and groups of patients. We have promising results so far that we hope to be able to share soon. So please stay tuned. And so I think this is a nice kind of takeaway slide here about what we think causal health tools should do, but I do want to make sure I spend at least a couple of minutes looking at how I think our recent work on large language models and the domain knowledge they capture can feed into this causal health layer to really make things quite exciting. So we got so I'm going to step back and say, why are we looking at these large language models at all? Why do we think they have any interesting causal knowledge? What are we trying to understand here? Our investigation began by looking at these types of examples where a person would ask a seemingly causal question about a decision. In this case, I have an example showing here from a toy shop owner wants to decide whether one ad or the other is going to be better. And they want to know which ad they should show next month. And we asked the LLM, GPT, to help them decide. And GPT gives a very reasonable answer, actually, and correct answer. Based on the available data, it's difficult to definitively attribute the increase in sales to the new ad because lots of other things are going on as well. There's confounding factors that aren't accounted for. And then recommends to make an informed decision, conduct an A/B test in the next month, divide your audience into two groups, see what works better. So GPT-4 is correctly identifying that there's potential confounds, lists one of them, the holiday season, and then recommends an experimental approach to figuring out the right answer. This is super exciting. At the same time, it gives wildly wrong causal advice as well. So we can't just blindly trust this, obviously. We have to understand what's really going on before we can do anything further with this. if we say that we then ran an experiment in February, and I won't go into the details of what we say here, but GPT-4 blindly says that sounds great. Here's your answer, ignoring all the confounds in a poorly set up experiment. And the same kind of causal knowledge that it had about confounds that it demonstrated in the previous answer, it completely seems to forget in the second answer. So what's going on? And so we decided to spend some time with these models to understand where we might be able to rely on them and why they might be doing what they're doing. This is a complicated landscape. Causality, as many of you or all of you are aware, is split across so many disciplines, across so many areas and approaches that we have to be very clear about what we're talking about. So in this paper that our working paper posted onto arXiv, we go through and we separately consider covariance-based analyses, logic-based causal analyses, implications of general causality and actual causality, and acknowledge that there's many different kinds of causal tasks as well. So in the next couple of slides, I'm going to dive into using large language models and the domain knowledge they capture for building causal graphs, those assumptions that are framing the first step of a causal analysis, including in the health context. So can we extract knowledge about causal relationships from a large language model? E.g., can we just ask the large language model, whether A causes B, or whether there's a confounding factor that would confuse the relationship we're seeing that would explain the relationship we're seeing between A and B. Like if we have, a night light at home and we see kids in that household developing myopia, what are the potential confounding factors that we should be considering? Would the large language model tell us? So to experiment with this, we pulled out a standard benchmark data set for causal discovery, the Tübingen benchmark, that lists a bunch of pairs of variables. Say, for example, variable A on this side is maybe cement, and then variable B is the compressive strength of the concrete. The data set then tells us whether the cement is causing the compressive strength of concrete or vice versa. Drinking water access and infant mortality. The data set tells us the benchmark is can we tell whether infant mortality is generating drinking water access issues or vice versa. The Tübingen benchmark is intended to be a benchmark for data-driven analysis. Can you look at the actual raw data measurements to identify whether variable A causes B or vice versa? We are going to ignore the data and just look at the metadata, the variable names, and see if GPT can pull the right answer out of the information that was included in its training data set. And so here we see an example of how we ask the question, which cause and effect relationship is more likely, A causes B or B causes A, and we see GPT answering correctly. And we see, when we dive into these results at scale, we see that data-driven causal discovery, does reasonably well, 83% accuracy, 81.5% weighted accuracy. But when we get into the knowledge-based causal discovery approaches that are ignoring the data, just looking at the memorized knowledge in the large language model, we see that these approaches are actually much better than the data-driven approaches. They're doing two different tasks, so this isn't intended to say that one is better than the other, but it's just an indication that there is a lot of potential here to pull out causal mechanisms for a diverse variety of tasks, of domains from a large language model. We do have to ask and be careful. What are we actually testing when we ask these questions pulled out of a Tübingen data set? In particular, we have to be careful, to ask ourselves: what does it mean? What would it mean if the large language model was actually trained on this data set? And it turns out that we can run some experiments and we can identify that that the Tübingen data set was actually included in the training data for these models, and that it has at least partially memorized them. We can give it the beginning of a row. We can say what the ID number is and give it like 1 or 2 columns, and it'll auto-complete the rest of the columns correctly a large percentage of the time. So we look at these tests not as telling us whether the model knows the answer at all. This information was in its training data set, so it does know the answer. What this experiment is telling us is the model able to transform the knowledge that it's embedded into its neural network? Is it able to transform that knowledge to answer a specific causal question that we have in a different format? And transform here means taking, for example, the knowledge it's read from this tabular data format that was in the Tübingen benchmark raw data that was included in the training data set, and take that tabular data format and then translate it into our English language question. In other benchmark experiments that we ran, the original data was in a graphical format or some other non-tabular format. And so there is certainly some translation that has to happen here to transform from whatever representation of this knowledge was in the original data and reliably convert it into a result that we can see that answers our question correctly. Beyond the Tübingen data set, we also worked with a couple of other data sets. We worked with one neuropathic pain data set, where the original data set was in a graph-based format, not a tabular format. So this requires more drastic transformation of knowledge. Here we see that GPT-4 is able to achieve 96% accuracy as well, reproducing these relationships, including indirect relationships embedded in the graph. We do find that full graph discovery is a bit more difficult. We don't see these 90% numbers when we're trying to recall a full causal graph across a large number of variables. So that's something where we think there's more work that can be done in strategies for pulling out pairwise relationships and expanding them. Some of the difficulty there comes out of the fact that we have to be careful about when we're asking for direct causal relationships versus indirect relationships. So what does this mean for the causal health layer? So if we have a large language model that's able to provide domain knowledge about unobserved confounds, about causal relationships based on the metadata that we're seeing in our observational data sets for a particular analysis, this is a significant help for bootstrapping and brainstorming with the human expert. It reduces the burden on that expert to be able to recreate all of the relevant factors in a given moment. We also are seeing early sign that the large language model may also be able to help identify negative controls and other validation approaches. For example, in one case study in the appendix of our working paper, we asked the large language model to help us identify negative controls for a study on vaccine efficacy inspired by Miguel Hernan's work, studying the COVID vaccine rollout in Israel. And we have to do a little bit more prompting to let it know that our data set is longitudinal, for example. But then once we've done that, it identifies very interesting negative controls quite well. And now we think that there are many open questions about how we can embed these LLMs into a causal health layer, what kind of additional knowledge we might bring to improve the efficacy of these large language models in a health scenario. Should we be using BioGPT, the biomedical fine-tuned version of some of these models, for example, or is there another way of augmenting the large language model's knowledge to support causal analyses? So we think this is a very exciting area where there's many open questions still. At this point, I'll pause or end the talk and say thank you to many people, both working on causal AI at Microsoft, collaborators in the Microsoft Health Futures team, as well as our collaborators in the open source community. I'll close with, repeating our core challenge that we identify as being really the causal framing and ensuring validity of these assumptions. We think causal software has a significant role to play in scaffolding these end-to-end analyses. And we think a causal platform for health can really bridge this gap to make sure practitioners follow best practices appropriate to the health domain by codifying shared knowledge and best practices, and then leveraging the best kind of advances in large language models to continue reducing the burden on people while ensuring that the analyses are correct.
Thank you very much, Emre. It was a very nice talk. So the floor is open for the audience. If you want to raise your hand, we'll open your microphone and ask your question. Meanwhile, I have two questions. So one was about the first part of your talk, about the validation. So for things like individual treatment effect, like when you want to validate, many of the cases we don't have access to RCT. So what are your general practices in DoWhy for validation when we don't have RCT access?
There are a number of tests. If we can't validate based on RCT, obviously that's very challenging. If there's, I think, relatively few scenarios where you want to be doing observational studies and yet still also have the ability to do RCTs. What we find is that we can still run many refutation tests. So we might not be able to prove that your assumptions are correct, but we can look for scenarios where we can disprove them, right, and prove them wrong. And that just means that that your analysis is wrong. The other thing that we recommend is to run sensitivity analyses, where we insert, say, synthetic data to simulate a violation of an assumption to either a small or a large degree, and then measure the relationship as we violate this assumption, more and more and more. How much do we have to violate it before our results change in a way that affects our decision, whatever decision we're trying to make or understanding we're trying to come to. Then you can take a look at how much this violation is how much this assumption is violated, and compare that to your understanding of the system and ask whether that's reasonable. If a small violation is switching your analysis results around, then that might be a big risk to the validity of your analysis. If it takes a huge violation, you might say that if that was happening, I would know about it.
And you can use that also for like validating the effect size estimation, like.
Yes, basically you get confidence bounds on your results. So this can be done analytically for some algorithms, and then it can be done like through bootstrapping more kind of mechanisms otherwise.
That's great, thank you. Well, we welcome audience for questions if anybody has a question. I think Jay has a question. So I don't know if Catherine, if you can open Jay's microphone, you can ask a question and have a discussion. Jay, you can ask a question in person, please.
Very great talk. I have one question about the, how to validate the correctness of your, result. Okay. Because we do not have ground truth, right, for such kind of problem. How to validate you are right? That's my question.
Yeah. There's many different strategies. In some scenarios, you can run small RCTs to augment kind of larger scale observational studies. We see this in many of our large scale internet service scenarios. Experiments are expensive, but they're possible. And so we use them to validate the approach. What we're doing with the Health Futures team is applying methods to recreate RCTs that have already been done to gain confidence in the methods themselves. That if we're able to recreate the RCT results from past studies, then we're going to trust these methods more in studies moving forward. I think that we do need to be careful about the limits of that type of approach when we're in a very new scenario. And in particular, risky scenarios, we should not. This is not an argument that we should not be doing an RCT, but there might be ways to use observational data to augment the RCT to speed the process, the clinical study process along faster.
Okay, thank you. Thank you very much.
Yeah. And of course, once you've made your decision, you should be monitoring your decision to ensure that the results that you're seeing are consistent with what you expect, given your observational analysis too.
Okay.
So Emre, I have a question about the second part of your talk. So my understanding of the second part of the talk is that we can use LLM in two ways. One, as a prior about the causal relationship that are already encoded, for example, in the literature, if you're using, for example, bio version of the chat GPT. And the second one is as kind of like a automatic, kind of like a reasoning engine. So, and my understanding of the approach is that, like, if you rename the name of your variables from what is actually is to, for example, ABC, there is no reason, there's no way that, for example, LLM can infer it. This is why, like, you need to use their actual name. But my question is about the second approach, the second application of the LLM, and more specifically using it as a reasoning. Have you ever tried, for example, to investigate the LLM capabilities in terms of how it knows the consistency? For example, if I have 3 random variables that does not follow the DAG, for example, they have a loop in it, is it able to infer that there is, for example, there should be a confounder outside of it? Like, have you ever tried that? So, for example, like if A, B, and C do not follow the DAG, A has a relationship with B, and B relationship with C, and then C relationship with A, then there should be some external confounder. Have you ever tried to investigate if LLM has these capabilities or need to be enhanced?
Yeah. So I think first, your characterization of the first part of how we use LLMs to recreate domain knowledge, pull it out of its training data set. That's correct. We're asking questions. What is does some variable feature does some factor cause another factor? And you're right that if we replace those with generic variable names, we lose the information that the LLM is leaning on to generate the right answer. So we can't just replace those variable names with A and B. We want to give it the variable names. In fact, we want to give it more context as well. One of the questions that the LLM got wrong in the Tübingen benchmark was about the causal relationship, the direction of relationship between ozone and radiation. And it gave the wrong answer. This was one of our experiments where we were actually asking, why did you justify your answer? And it turns out that it was interpreting that ozone and radiation relationships are ambiguous. When you're talking about ozone and radon at ground level, the relationship goes one direction. When you're talking about ozone in the stratosphere and UV radiation, the relationship goes in the other direction. And the LLM was interpreting it the other way. So beyond the variables, actually giving additional context about your setting is I think very important. And I think we might even find strategies useful that ask the LLM explicitly, is there any factor that would change your answer? Like, would the causal mechanism ever go the other way, and see what it responds with, and et cetera. And of course, we have to find ways to automate this as well, so that it's we are continuing to reduce the burden on the human analysts and not just giving them different work to do. We want them to perform better and have better results overall, not be doing something that feels like busy work. The causal reasoning, I think, I'm a little more skeptical that large language models are reliably today doing causal reasoning. They seem to be doing a reasonable, answering a lot of questions correctly when doing simple reasoning tasks like one-hop reasoning, etc. But in many longer range planning and reasoning tasks and longer range analysis where it feels like they are not doing as well. So we see them being useful for contextualizing and bringing common sense knowledge to a particular problem. So, for example, we can ask counterfactual questions of the form like, if a doctor a doctor washes their hand and then goes sees the patient, what would happen if the doctor didn't wash their hands? The LLMs contextualizes this and says the patient might have gotten an infection. And the word infection was not mentioned in the original scenario, but it's able to bring it in as something that's a relevant factor. And so it does a really good job with the causal framing of the task and identifying factors that are related to your question and your scenario. But once you start getting into complex reasoning, it doesn't work as well. We see this also in graph analyses. You asked about the relationship between A, B, and C being a cycle, and what happens when you ask about that. We haven't asked that question about cycles specifically, but we find that when we're doing graph analyses, experiments trying to see what large language models can do, that large language models are able to do well at local analyses. But once you start to get into like multi-hop analyses or global properties of a graph, say like connectivity degrees and and things like that, then it fails.
It's interesting. Thank you very much. If there is no further question from the audience, we thank you very much, Emre, for the talk.
Thank you. It was great to be here. I really appreciate it.
I hope to see you next time in person. Thank you.
Thank you.
Hope so.
Take care.